In this episode of the ASC Podcast with John Goehle, we explore the latest updates in the ASC industry, discuss recent challenges and survey experiences, review a new change and how CMS survey results are reported publicly, highlight National Timeout Day, and dive into best practices for peer review. Plus, in our focus segment, we do a deep dive into the requirements for a robust infection control program.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, Amsurg, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 249 of the ASC Podcast with John Goehle, recorded on June 22nd, 2025 from our studio in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and to keep up with any updates or new guidelines released by relevant regulatory authorities. And joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and finance management.
So I think one of the biggest pieces of news right now is that this coming Thursday, our lives are going to be upended a little bit. We get a new puppy.
Yes, we do.
You've heard about our escapades with Rosie, our English cream golden retriever, who turned 5 this year, and now we're getting a new puppy just to expand our puppy business here.
Continue the fun.
Continue the fun. So we'll have some great stories and escapades there. And, of course, in our virtual conferences, we'll make sure the puppy makes her periodic visits. Sue, you've kept me on the road, haven't you? Sue is in charge of my schedule, so she makes sure that I'm always busy. And we've had, I think we figured it out, we had 7 surveys over an 8-day period.
Yep. And so kept the whole team busy.
That's right. Yep. That's right. And I personally was on site for 7 of those surveys. So that is a new record. And by the way, they were all, really great surveys overall, even for those organizations that, sometimes we get called in very late in the process. And we had one center in particular, we only had about 3 months of preparation, and we were able to get them over the finish line there. So really great surveys. Congratulations to all those organizations that got through them. Of course, now we have to do the plan of correction. There's always a plan of correction out there. But we're very proud of our clients and the hard work that they put into getting prepared for a survey. And, to that end, one of the things that we've been working on, Sue, is our patron drop-in sessions, as we've mentioned many times in the past. One of the big benefits of being a patron member of the podcast is being able to do what usually it's weekly. It's not, I think probably we do it about 42, 44 times a year. Yeah. So it's almost always weekly. But we've moved them in the last probably about 3 weeks.
Well, we try different things, right? So we've gone to Fridays. We've occasionally done a Monday.
Monday, yeah. Generally, they're Saturdays, but for the last, I think it's 3 weeks, we've been doing it on Fridays, and we've had a great attendance at these sessions.
I don't know why. I guess people don't want to spend their summer Saturdays
I don't understand.
talking to us about regulations, but we do. It does seem to work out really well for people when we do it during the week. And some people do better on Saturday. So I think if we kind of play around with it, everybody can get a chance to, come in if they have a question.
So we've really had some great conversations. Of course, the surveys are fresh in our minds when we get to Friday. So just a lot of good discussions, a lot of good questions. And, not everybody asks a question while they're on. Sometimes people just sit in the background and listen. But it's a great way to kind of get ready for a survey, celebrate when somebody passes a survey, or just ask questions of surveyors. I think generally we have at least 3 surveyors on these weekly drop-in sessions. So if you want to join us, follow the link in the show notes to become a patron member today, and you'll get notified every time we have a drop-in session. So we haven't heard from CMS in a while, more specifically the Quality Safety Oversight memos to the state agencies. And we've talked about this quite a bit in the past, but we really haven't had one that directly impacts ambulatory surgery centers for well over 6 months, and certainly since the new administration came in. So we do have the first release, the first policy memo of the new administration, and it is called QSO 2519-all, meaning that it affects all healthcare providers. And it has to do with the CMS 2567, which is the Statement of Deficiencies and Plan of Correction. For those of you that have been around a while, this form's been around ever since, I've been in the business, which is about 36 years now. And it's used by the state agencies to document the Statement of Deficiencies and to provide space for the surgery center to enter the Plan of Correction information. So that's what a 2567 is. It's a standard form that all of you who have been around a while are probably familiar with. And we know that we get the 2567 within probably about 10 business days of the end of the survey. And then we have 10 calendar days to respond to it and to file a plan of correction. And that gets to the heart of what change has occurred here. So the previous practice by CMS was that they held the public release of the information from the 2567 for up to 90 days after the completion of the survey, or until a plan of correction has been approved by the state agency or CMS. Doing so often delayed the release of important quality and safety findings to the public based on when the provider submitted their plan of correction and the duration of the subsequent administrative review by the CMS. So the administration, in looking at this and kind of implementing their new Make America Healthy Again initiative, feels that transparency is very important. So what's important to know is that as opposed to that 90-day window, the administration now is saying that the plan of correction is releasable upon approval by CMS. In other words, there isn't a mandatory 90-day holding period there. And this is the statement that they made in this release. It said, adopting the immediate release policy across all providers and suppliers enhances public transparency and streamlines administrative processes. With greater transparency and more timely access to survey information, beneficiaries are able to make informed decisions about where they receive their care, affecting the commitment of the administration to make America healthy again. So the actual memorandum summary can be a little bit confusing, but what it does say is that the official form, the 2567, will be publicly releasable within 14 days after receipt by the provider, supplier, or lab. In other words, the 2567 can be immediately released upon receipt by the provider up till 14 days. So that got very confusing for the two of us as we were putting together the script for this, but I think it's kind of important to remember that now there is that not a mandatory 90-day time frame for the release. Now, Sue, as you and I were talking about before we recorded this, it's not really generally public knowledge that the results of your survey is publicly available. And when you and I were talking about it, I said, I don't know that I've actually ever been able to find a website where I can look at this. And I did again verify that just recently that, through Google searches, I couldn't find a single situation where I was able to read somebody's plan of correction or statement of deficiencies. So maybe I didn't do it too thoroughly, but I know you can do it for like nursing homes and you can do it for hospitals, but I haven't been able to see it with surgery centers. And that might be because I wasn't looking at any particular state here. But I think it's important to note that with the new transparency of this administration, that I think we're going to find a bigger focus on making sure this information is available.
And I mean, people do have the right to know more information about the places they're going to, but the problem is not everybody might understand exactly what some of those mean, and that you are fixing things that come up, So I don't know if it means they then release a plan of correction and say, okay, this is fixed. I guess we're really not exactly sure.
And because we haven't been able to see examples of it. And I think my concern, I mean, as a consumer of this information, I like to have this information. As particular, I used to be in the nursing home industry, and certainly as a consumer of nursing home information, you want to be able to see what's going on. And the same thing with surgery centers. So from the public standpoint, this is a good idea, but we as providers know full well that sometimes we get that statement of deficiency and there's things that are incorrect in there that we have to fight. Or as you said, Sue, the context is not there. We can't, maybe the people that are reading it don't quite understand that it's pretty normal to find things during a survey, but somebody that's reading this on a website might not quite understand that. So just be prepared for the public to have information about your most recent survey, and act accordingly, and be prepared to be able to answer their questions if somebody calls you up before surgery and asks about a recent survey.
And like you always say, always be prepared, because the fewer things that they cite, they'll always cite something, but you'd rather have it be less serious, obviously.
Yeah. So, Sue, we had a celebration last week. Sorry, we missed it with our podcast, but June 11th was National Timeout Day.
And there was a great article by Madeline Jo May in OR Today that discussed how to improve your timeout. So even with the implementation of the timeout process and all of the advances in technology that we've seen in recent years, we still have quite a ways to go to improve patient safety in the OR. And this report focused on the issue of consistency versus complacency. So in the timeout process, obviously we focus on routine so that nothing's forgotten. Often people have a checklist they kind of go through. But the problem is that can cause the participants to kind of lose focus, and the process becomes so routine that it's just not effective. Everybody sort of nods their head or goes about their business. They recommend regular training and encouraging active team engagement, of course, and varying your approach to the process. So this was the more interesting part of it. They suggested using the PDSA framework to do your training. So the first is plan. So review the process and each element on your checklist, and add this review to the agenda in some of your future education sessions. So you can always be looking at it and getting feedback. And then the do is implementing the training and varying your approach. For example, review the roles and responsibilities during the timeout, so all team members have a stake in that process and hopefully will pay more attention. Consider distinct timeouts in each phase, like before anesthesia, before incision, before leaving the OR. And I thought this was interesting. They suggested doing a mock timeout. So have the surgeon or whatever leader is usually does the timeouts make deliberate errors to train the team to listen carefully and to be comfortable speaking out. Now, obviously, it's important to make them not real obvious so that people really have to focus and say, wait a minute, I don't think that's right. You could also switch roles so everybody can see the process from other perspectives. And even the simple thing, even though they know it's a mock, just getting used to, kind of putting your hand up or saying something is really good practice, because a lot of people it's in that setting, they don't want to, speak up if they're not somebody used to doing that. And then study, conduct audits of the timeouts and ask for feedback from the team, and ACT, which is sharing the results with the team and make sure they feel involved in the process of improving patient safety.
So the timeout is one of those things, Sue, that I'm very passionate about, and it is a frequent problem. More than 50% of the time, I think, during a survey or during a mock survey, I find a problem with the timeout. And I've done investigations of bad outcomes. And in many of those investigations, unfortunately, some that have involved, patient death, the timeout is part of the problem. We've had timeouts that have been missed that have resulted in patients having the wrong side surgery, wrong person surgery, et cetera. And it is such an important part of it. And to your point, it very frequently, it's like people are whispering the timeout, or they just don't speak up, or, I frequently see the anesthesiologist, unfortunately, who is very busy at that time, working hard, or the rad tech, if the rad tech is involved in the procedure, who is working on the machine. So you need to do exactly what it's called, a timeout, where you just stop everything and take just a few seconds or or a minute to determine that you're doing the right thing in the right place on the right patient. So,
and I do like the idea of switching it up, because
I do too.
You can't possibly hear the same thing over and over and over again and be able to really pay attention to what they're saying. And a few episodes ago, we had spoken about a case where the correct implant was not available, and somebody ran out and got it. It ended up being flash sterilized, which is not appropriate for an implant. But, that could have been easily caught if they had just, put that in the timeout. Or maybe they did put it in the timeout, but people are just so used to going, yeah, we've got all the stuff that we need, that nobody noticed.
And it was too far into the procedure to be able to do anything differently.
Well, they could have stopped the procedure.
Other than stopping the procedure.
But, you don't want to be in that position either.
And then you saw an article in the Miami Herald.
So this was a little bit scary. 2 men in Florida are accused of operating without a license. They had each promoted themselves as surgeons on social media. Kind of odd, and at least one patient suffered permanent disfigurement when they had a surgical procedure done by one of these people. On the arrest forms, they were both referred to as surgical assistants. So I'm not sure if that's what they really were, and they just decided they would make more money, pretend they were a doctor. But they're both facing criminal charges. And the owner of the surgery center apparently was in one of the surgeries with one of these people. So the Florida Department of Health issued an emergency suspension order on the surgical center's license in May. And I don't know, I think it's still under the process. I don't know if they lost it permanently. And I would say it's important, to do credentialing, obviously, but I don't know if this person knew anyways, but, it's just one of those things that reminds you how important it is. People can say anything they want. And you really have to look at credentials, everything. And there's a good reason for it, especially if that person that you're recruiting is not known to you or to other providers in your organization. Yeah. So, Sue, we've had some big news this week with a lot of M&A activity in the ASC field. Our friends over at ASC News referred to it as a blockbuster day for ASC deals when Ascension acquired Amsurg. So what happened here is Bloomberg reported that Ascension was in advanced talks to acquire the ambulatory surgery center giant Amsurg for a $3.9 billion deal. Ascension announced that it had an acquisition agreement in place as of June 17th, and though its announcement did not provide financial terms for the deal. Ascension described the move as a strategic and mission-aligned acquisition that marks a milestone in Ascension's journey to transform healthcare delivery. And they indicated that this acquisition is deeply aligned with Ascension's mission to provide compassionate, personalized care to all, especially those most in need. And it reflects our steadfast commitment to expanding access to care in a way that is more affordable, more local, and more centered around the dignity and well-being of all that they serve. Once finalized, the deal for Amsurg would add 250 ASCs across 34 states to the Ascension network. So that's a big deal. Amsurg, of course, has been growing pretty dramatically. We'll see if this deal provides them more resources to continue growing. And then Reuters reported last week that Surgery Partners rejected Bain Capital's take private offer. In other words, an offer to take the publicly held organization, Surgery Partners, private again. Surgery Partners said it was unable to agree to the terms by Bain Capital, a private equity group, its largest shareholder, to take the surgical facility operator private. The special committee of independent directors had concluded that the best path forward for the company and its stockholders was to continue operating as an independent, publicly traded company. So
a lot of news coming out of that, and certainly there's a lot of activity. I look at this as another sign that ambulatory surgery centers have really come to the limelight recently.
Yeah.
And the fact that public money is out there chasing after surgery centers, chasing after owners of surgery centers.
As our hospitals, they're just
True.
very much in demand right now.
Right, and just a reflection of how important healthcare is as part of our economy. So more to come on that one, and I know we don't generally talk about merger and acquisition activity, but I did think that was kind of important. And Sue, we've had some interesting recent experiences. One of those has to do with peer review. Just a reminder that peer review is not just random chart audits. So to ensure that you have a robust peer review program in your ASC, you have to make sure that you establish clear criteria for your peer review program. You want to define objectives, specific criteria for evaluating practitioner, the surgeon performance, and align it with current standards of care and the ASC scope of services. And as I said, you want to go beyond random chart audits. Peer review must evaluate the full scope of care delivered by each provider. And this includes reviewing their outcomes, complications, adherence to surgical protocols, and consistency with quality data. For example, infection rates, case cancellations, patient satisfaction, and adverse events. So you want to make sure that you're integrating your peer review program with QAPI. And if you look at the most recent update to the 888C standards, you'll see a real integration there. I've done a couple surveys, well, quite a number actually, surveys under the new system, and it's very apparent how closely aligned peer review and QAPI is. So make sure that you can define to a surveyor how integrated those two programs are. So you want to ensure that peer review findings feed directly into your QAPI program and use QAPI data to help identify practitioners or trends that warrant a focused review. And you want to document deliberately. In other words, maintain thorough, confidential documentation of peer review activity, findings, and follow-up actions. And a question came to me, actually, in an organization that I was surveying, how do I document this peer review? Should I put it in the credential charts? I do not recommend that. I recommend for each of your providers have a separate credentialing and privileging file and a separate peer review file so that information is kept distinct. Surveyors often cite ASCs for having peer review in name only without documented evidence of any meaningful evaluations, and that certainly is an observation that I see regularly. And you want to conduct peer review consistently, for example, quarterly, with results formally presented to the Medical Executive Committee and the governing body for review and action. And you do need to train your peer reviewers, designate qualified peers to conduct reviews and provide them with orientation or training to ensure their consistency, objectivity, and understanding of their role. Don't make this just a let's check all those boxes type thing. And then you want to report and then you want to prepare some type of a summary. I call it a report card. That's not necessarily a good term there, but something that summarizes all the information that you've gathered. And make sure, of course, you report the results to the governing body.
And it does seem like it should go without saying, but a peer has to be a peer of that doctor, surgeon, whatever. The nurse, the administrator can certainly help by, presenting the charts to them to, show them where to fill things out, make it as easy as you can. But they have to use their medical judgment. It just, like you said, it's not just looking at things, boxes are checked. They have to make sure that it has to be somebody that has that same level of knowledge.
Right. I did have a recent survey that I did for an accrediting organization where the governing body only met once a year, and there were no references at all to the governing body in the QAPI data. So that's another thing I just want to emphasize, how important it is for the governing body to have information that demonstrates that they are following the conditions for coverage with regard to their oversight of the quality improvement program. So, Sue, we noticed that we haven't talked about infection control in a while, so I thought that we would discuss it this week. So let's take a short break, and when we come back, we'll talk about infection control. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? more importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. So welcome back for our focus segment on infection control. Sue, we haven't talked about this in a while. I mean, we talk about infection control throughout the podcast, but we don't really go back to the regulatory backbone for it. And this is a topic that is the forefront of many surveyors out there.
I agree, John. It's been really a long time since we've covered infection control really in detail and done a deep dive. And with CMS and accreditation surveys getting stricter, I think it's a really good time to look a little bit deeper. And it's all about, obviously, patient safety and keeping your ASC compliant.
Right. Well said. Today we're going to start by, like we always do, start with the regulations, building a robust program, appointing and training a coordinator, including who can fill that role as a coordinator, how we conduct risk assessments, how we monitor for infections, how we perform surveillance activities, the reporting to quality improvement committees, and what surveyors are looking for, including the serious consequences of breaches that can occur, resulting in an immediate jeopardy. As a surveyor, I'm going to share some of my insights, and we'll lean heavily into the ASC CMS interpretive guidelines to clarify expectations. So as we all know, the CMS conditions for coverage for ambulatory surgery centers are located in the Code of Federal Regulations, Part 416. And the one related to infection control is 416.51. Now, interestingly, Sue, it's not a very long area for such an important item to discuss. So it's easy for us to kind of read through it verbatim. And let's take it verbatim from 416.51, the condition for coverage for infection control. The ASC must maintain an infection control program that seeks to minimize infections and communicable diseases.
And standard A, sanitary environment. The ASC must provide a functional and sanitary environment for the provision of surgical services by adhering to professionally acceptable standards of practice.
And B is the standard is infection control program. The ASC must maintain an ongoing program designed to prevent, control, and investigate infections and communicable diseases. In addition, the infection control program must include documentation that the ASC has considered, selected, and implemented nationally recognized infection control guidelines. The program is, number one, under the direction of a designated and qualified professional who has training in infection control. Two, it's an integral part of the ASC's quality assessment and performance improvement program. Three, responsible for providing a plan of action for preventing, identifying, and managing infections and communicable diseases, and for immediately implementing corrective and preventive measures that result in improvement. Now, interestingly, by the way, the 416.51 was most recently updated in October of 2024. So it's important for everybody to stay on top of these regulations because they do change frequently.
Yeah, and these regulations are full of requirements, but the interpretive guidelines are the key to really understanding what surveyors expect. So we're going to take a look at those.
Absolutely. The interpretive guidelines are like that surveyor's playbook. Kind of, they're
Open
the
book
instructions.
test, you always say.
Yeah, that's an open book
Right?
test, exactly. It's what we use. All of us surveyors keep a copy of it with us as we're going along. And as you said, Sue, it's an open book test. You can see the very questions that a surveyor is going to ask. And it offers, granular insights as to how compliance is assessed. As you've seen, the actual regulations are pretty short. So it takes a lot of words to actually be able to help a surveyor to identify whether an organization is in compliance. Let's break the regulations down with a focus on what they mean for ASCs. We're not going to actually read the interpretive guidelines because they are quite in-depth. And, of course, we'll provide a link to them in the show notes. But let's just paraphrase, Sue, some of the interpretive guidelines here and add some commentary as we go along. So why don't we start with the sanitary environment?
So the sanitary environment, which is 416.51a, this standard requires ASCs to maintain a clean, hygienic setting to prevent healthcare-associated infections. The interpretive guidelines specify that this includes proper cleaning and disinfection of environmental surfaces, medical equipment, and surgical instruments, as well as safe waste disposal and adequate ventilation in the ORs. Surveyors expect ASCs to follow manufacturers' instructions for disinfectants and sterilization processes, adhere to aseptic techniques during procedures, and maintain air handling systems to prevent airborne contamination. The guidelines also highlight the importance of food sanitation in employee areas and water quality control, especially during renovations. That's a lot to cover. So sounds like surveyors are looking for everything from how you clean a crash cart to the air filters in your OR.
Yeah, exactly. And of course, one of the challenges that we have as a surveyor, sometimes we ask questions of the director of nursing who knows what's going on in the operating room, in the treatment rooms, in the PACU, and the pre-op area, but they actually don't know much about how the air handling systems work. So it is important that at least you have a good understanding of your air handling systems and know who to ask in your organization about that. The guidelines note that surveyors may inspect high-touch surfaces like doorknobs, light switches, or IV poles for visible soil. They need to check the sterilization logs for endoscopes or other surgical instruments and verify that OR ventilation meets the standards of ASHRAE 170 for air exchanges. And they're also going to look at your policies. We spend a lot of time reading through your policies, say how you handle soiled linens or dispose of biohazardous waste. And then you want to confirm that staff have been trained on these protocols. And I'm going to ask questions of your staff as I go along to make sure that they've read the policies, are familiar with the policies, and are actually doing what the policies say. Non-compliance, like using an outdated disinfectant or one that's not approved or skipping sterilization steps, can lead to citations as guidelines tie this directly to patient safety risk. And I think so it's important to note that these are one of the most common situations where we have an immediate jeopardy if we see some violations of those. And we mention on this podcast a lot the importance of the instructions for use, manufacturer's instructions. And I don't think we can overemphasize that.
Now, you have to be using them, but also they may very well ask you to show them where they are. Where are those directions for everything, like we said, from your chemicals that you use to your equipment, and you better know where those are.
And train regularly your staff members on that. Yeah. And the other thing that I've seen recently is that people switch products and forget to change the instructions for use and the manufacturer's instructions. And
or product could just be updated.
Right.
So check those periodically. Make sure that, you don't just get in the habit of replacing things and then not noticing if maybe the instructions have changed a bit.
Well, and to that point, I was actually in a survey this last week, and I was observing them cleaning a stretcher using a Cavi wipe. And I asked how long they have to keep it there. And she says, I think it's 2 minutes. And I said, do you think, or are you sure? Sure enough, we pulled the instructions for use and it said 4 minutes. Yeah. Again, I did not cite her for that because she immediately corrected it, but I probably could have cited her. For that particular situation. So we are going to confirm with your employees that they're trained, that they're knowledgeable, and of course we're going to be timing it too to make sure that they're actually doing that amount of time.
So to put this into practice, ASCs need detailed cleaning schedules, staff training records, and regular environmental audits to stay on top of all of this. And I've heard of surveyors finding dust on OR counters or on the tops of door frames.
Yeah.
I know you go around and kind of run your finger the white glove test, right?
I don't have a white glove, but I can tell. Yeah, no, that's a good point. And that high touch surfaces are important, but also looking for areas that might not be regularly thought of. Like the top of a machine or something that's hard to reach. I'm going to check that to make sure there's no dust up there.
And your patients definitely notice this stuff.
Yeah.
I've been in doctor's offices or clinics or, the hospital, and you kind of look at the corners, and it's things I think you don't see when you're there every day. And you really notice a lot, and it doesn't feel good to look around and feel like it hasn't been cleaned in the corners in quite a while.
And to that point, that's a very good point, is that sometimes we get so used to our environment, kind of like what you were talking in the beginning, in our beginning segment, we were talking about how we get very complacent about our timeouts. We get complacent about cleaning too. We're not always checking to make sure that the place is absolutely clean. We look past those areas that have been an ongoing problem. And I do want to point out that the guidelines emphasize that even minor lapses like improper storage of sterile supplies can compromise the environment. ASCs should conduct environmental rounds with a checklist and document any corrective actions like replacing a faulty air filter to show surveyors that they're proactive. And don't be afraid to document that something's not right, and then, of course, document how you fixed it. Yes. I get pretty upset when I go in and I see an environmental rounds that has everything perfect and I see something wrong, and something that obviously has been wrong for a while. Yeah. Or when I'm talking to the staff, when I see the records that show no problems, and then I talk to them and say, oh, yeah, last week we had a problem like this. Clearly they're not documenting properly. Yeah. We're not citing you because of things that you put in those checklists. Yeah. We're citing you when you don't catch things on those checklists. Yeah,
it's sort of backwards from what a lot of people think. Like, they're like, I don't want to point out problems to the surveyor. But that's how you show active quality improvement. Right.
Another good example of that is hand hygiene. I walked into a place the other day, 100% hand hygiene, and it was actually quite poor. There was more than 50% breaches going on consistently. And I said, I got to tell you, I don't believe any of your hand hygiene audits. I don't think you're actually taking it very seriously. Yeah. And, she was kind of upset at my comment. But on the other hand, it was quite obvious to me that that the staff didn't know proper hand hygiene. And whoever was doing the hand hygiene surveillance either was just checking the boxes off, or they weren't familiar with what the actual rules are.
Just have to be honest so that they see what it is you're documenting when they get there. I know I had somebody once ask me, well, what number should it be?
Yeah.
Or what percentage?
like they were going to create a number.
It is.
Yeah, that's right. Yeah.
And you should make sure everybody's not just behaving when they see you coming around with your little notepad.
Well, and that's a really good point. That's a recommendation I think we talked about recently where, have other people do the surveillance periodically. Make sure they're well trained on doing that surveillance so that they're not going to know necessarily when somebody's observing them. Let's move on to the infection control program itself, which is 416.51b.
The Infection Control Program Standard is the heart of the regulation, requiring an ongoing data-driven effort to prevent, control, and investigate infections. The interpretive guidelines outline several key expectations.
So first of all, we start with the actual guidelines that the organization has accepted or is using. The ASCs must document that they've selected and implemented standards from organizations such as the CDC. Really, everybody's going to be using CDC standards. You may or may not choose ARN or APIC. If you're a GI center, you're probably going to be using SG&A. Whatever standards you use, make sure it's very well laid out in the infection control program. Surveyors will review your infection control program to confirm that these guidelines are referenced and that they're followed, such as the CDC's core infection prevention practices or ARN sterilization protocols.
And the program must be led by a qualified professional with documented training in infection control. The guidelines don't mandate a specific certification like the CIC, but they expect training relevant to ASC settings and that it covers topics like hand hygiene, sterilization, and surveillance.
And I guess we should point out, too, that CAPE is the newer certification out there. And again, CMS isn't really too familiar with CAPE at this point, and that's not one of those expectations. But that, having a CAPE certification definitely helps to prove that you have the specific training. So one of the problems that I see periodically is when I ask for proof of training, sometimes people give me a certificate that shows they've had infection control training, like you as a nurse are required on I can't remember how frequently, but you have to go through an approved infection control program. Yeah, but it's
so
not
that doesn't count.
Right, because it's not teaching you how to run a program. It teaches you how to practice good infection control. So those certificates are not going to be valid. We're going to be looking for a certificate that really shows that you have a background or knowledge in designing and implementing a program. And then you want to integrate your program with the QAPI program. The program must be embedded in the ASC's Quality Assessment and Performance Improvement, or QAPI framework, meaning that infection control data like the surgical site infection rates or hand hygiene compliance must be tracked, analyzed, and used for improvement projects and improvement surveillance. Surveyors will check QAPI meeting minutes for evidence of infection control discussions and actions. And just this last week when I was doing a survey, I saw a QAPI program that actually didn't even reference infection control. So clearly they were in violation of this particular area. And then you got to develop a plan of action. The guidelines require a written plan detailing how that ASC is going to prevent, identify, and manage any infections that it does find, including surveillance strategies, staff education, and protocols for outbreaks or exposures. For example, a patient with MRSA. The plan must be evaluated annually and updated based upon new risks, like adding a new surgical service.
And then you want immediate corrective measures. The program must enable rapid response to issues like isolating a patient with a communicable disease or retraining your staff after a sterilization lapse. Surveyors will look for documentation of these actions to ensure improvements are sustained. So that's a pretty detailed list. And as you know, John, and you've said many times, the surveyors want to see a living, breathing program, not just a binder and checklists, and they want to see that you're reacting to what you find.
Right. You don't want to see dust collecting on that binder in there. And I can't tell you how many times I see that. And I guess we could say that for policies in general, right? If that policy manual is not beaten up, if it's not, got a lot of sticky notes in there, and please don't just stick them randomly in there.
I was going to say, don't go just beat it against the wall and splash some water on it.
Yeah, I want to see that a beloved document that everybody really refers back. And the guidelines stress that the program must be ongoing and comprehensive, meaning that it's actively monitored and adjusted. For example, if your risk assessment identifies high surgical site infection rates in orthopedic procedures, surveyors are going to expect surveillance data. They're going to expect probably a QAPI project to address it. And, of course, evidence that the governing body approved those corrective measures. That's critical, too, is that in order to demonstrate the governing body is actively involved in quality, you need to demonstrate their activities in the governing body minutes. For example, you might implement new antibiotic protocols if that's something that's identified as missing in your program. And the surveyors are also going to check that the coordinator has the authority and time to lead the work, which ties into how that role is structured. So Sue, this is where there is a distinction between a hospital infection control program and a surgery center infection control program, and why a coordinator in a hospital is probably not going to have the same skill set that somebody has in a surgery center. That's one of the reasons why I'm not a big fan of the CIC program. I think it's an excellent program for people that are in hospitals, and it's a good certification, but it really doesn't help somebody in the ambulatory surgery setting because they're not likely to have to actually deal with an infection. They're going to identify an infection and, a communicable disease, for example, and then turf that patient off to the hospital. So having a deep knowledge of that, as a CIC does, isn't really necessary in the surgical setting, which means that the individual that's appointed as a coordinator in a surgery center has to have much more of a focus on preventing patients from coming in that have communicable diseases, identifying when somebody has that disease and has to be turfed off, and of course keeping an eye on your own employees to make sure that they don't show up with some type of communicable disease.
So now we want to look at what surveyors will be looking for during a survey.
So as a surveyor, infection control is a top priority. The interpreted guidelines shape our approach, and here's what we're going to focus on. First of all, documentation. We review the infection control plan. We're going to look at the coordinator appointment. We're going to want to make sure that they're been approved by the governing body. We're going to be looking at training records. We're going to be looking at risk assessments, and we're going to be looking, of course, at the QAPI minutes. The guidelines require these to be complete and current. Missing records or outdated plans are immediate citations, and we're going to be observing. We watch staff for hand hygiene, aseptic technique in the operating room, and cleaning between cases. And the guidelines highlight lapses like skipping hand hygiene or reusing single-use items as a high risk for infections. And then, of course, we're going to be watching the environment. We inspect operating rooms, sterile processing, and patient areas for cleanliness, proper storage, and ventilation. And the guidelines flag issues like overfilled sharps containers or improper sterile supply storage as sanitary environment failures. And then we're going to be asking the coordinator a lot of questions. We're going to ask them to explain the program, and we're going to be quizzing the staff on the various protocols like bloodborne pathogen response or outbreak management. The guidelines expect staff to demonstrate knowledge of ASC-specific risks like surgical site infection prevention. And surveillance is really key here. Most surgery centers really don't have a lot of infections, knock on wood. And therefore, surveillance is one of those activities that is most notable or it's something that we're absolutely going to have to see if we don't see infections. So we're going to be reviewing infection rates, hand hygiene compliance, and audit results, ensuring the ASC acts on its findings. The guidelines require data-driven improvements like QAPI project to address low compliance.
So that's a lot. What happens if surveyors do find major breaches?
Yeah, the guidelines classify serious breaches like improper sterilization or no hand hygiene or contaminated equipment as what we refer to as an immediate jeopardy situation, meaning a substantial risk of patient harm. I've seen ASCs cited for immediate jeopardy when they reuse single-use devices without reprocessing or fail to clean endoscopes properly. Immediate jeopardy triggers emergency corrective plans that have to be implemented immediately to be able to continue operations. And they're going to trigger follow-up surveys or even loss of Medicare certification if the organization doesn't resolve those issues on a timely basis. The guidelines emphasize rapid correction to protect patients, and surveyors will escalate those findings immediately.
I guess that's why we're spending a lot of time talking about it today and why we bring up infection control so often.
That's so true. So let's go back to the infection control coordinator for a second. That coordinator is a pivotal role, and the interpreted guidelines stress that they must have training and time to lead the program. In small ASCs, the director of nursing often serves as that coordinator, which works if they have dedicated time for infection control duties. And you can also split responsibilities. Say one staff handles surveillance, another handles training, but one person must be the designated lead. You don't want to split this particular function. Larger ASCs might actually have a full-time infection control coordinator, allowing a deeper focus on data analysis and audits. And particularly if you're doing procedures that are likely to result in infections, such as orthopedics. We don't see a lot of, I guess I should be knocking on wood, right? We don't see a lot of infections in like pain management centers or GI centers, but definitely orthopedics tends to have a higher rate of infection. And that's a situation, if there's a high volume of cases in that type of a facility, you probably should have a full-time infection control coordinator. But regardless of the structure, the governing body is responsible for appointing that individual and, of course, granting them authority to oversee the program. So make sure that your governing body minutes actually show an appointment of that individual and follow up on a regular basis to their functions.
And again, that time allocation is so important. We've seen small ASCs that struggle when the director of nursing is swamped with other roles. The guidelines are clear. The coordinator needs sufficient time, whether it's a few hours weekly or full-time. It all depends on the size and their other duties. They have to manage surveillance, audits, and QAPI integration, and they need time for the training. I've seen newly appointed or being ready to be appointed, people struggle just to get the time to go through a program.
And that training is so critical before they actually get into the role.
Yeah.
Otherwise, they're going to be spinning their wheels or perhaps performing things that aren't necessary or not performing things that are necessary. So again, takeaway here is that make sure that coordinator has plenty of time to carry out their functions. And by the way, the infection control section of the surveyor's questions requires us to ask how many hours per week that infection control coordinator is spending on infection control activities. Now, one little hint here is that if that person is also like a nurse, a circulating nurse, don't just talk about that time that they're spending on paperwork. When they're walking around, when they're observing what's going on, when they're doing their other duties, I tend to include that time also because, hopefully a good infection control coordinator is constantly observing what's going on with their colleagues.
That's a great way to get accurate data, too, because you're not, like we said before, walking around just with your notepad. You're doing other things, and you're noticing, oh, that person didn't wash their hands, or look, that, dwell time with the cleanser wasn't good enough. So it's important to always kind of be gathering that data in your head.
Yeah, right. And remembering to write it down, which is, of course, one of my problems. But, so carry a notepad around a lot. Now, the interpreted guidelines specify that the coordinator's training must be relevant to infection control oversight. Has to cover regulations, hand hygiene, sterilization, surveillance, and other ASC-specific risks like surgical site infections and communicable diseases. So we're gonna make a pitch here for our training program. So ASC Central at asc-central.com, and we'll provide a link here, offers tailored programs, and our two programs are Infection Control 101, which is training for infection control coordinators and ASCs, and Infection Control 201, which is advanced training for infection control coordinators. They were both recorded in September 2024, and you're going to find them on the ASC website. Links will be in the show notes.
And we think those courses are ideal because they focus on ASCs, unlike hospital-centric programs. The guidelines expect ongoing training, so coordinators should attend annual updates or webinars and keep a spreadsheet logging course names, dates, and contact hours to show the surveyors a coordinator, whether it's the director of nursing or a full-time infection preventionist, is well equipped to carry out her role.
Right. And one thing that I do want to point out, too, is that it's not just training programs, like official training programs, that demonstrate ongoing compliance with this particular area. If the infection control coordinator is spending time reading journals and then educating the staff on what they read, that, in my view, is training also. So, but make sure you're documenting that in your infection control binder. So, again, you don't have to spend a lot of money on this. You do need to spend some money to train the infection control coordinator, but the ongoing updates can be, I think you really should be sending them away or having some type of training programs, but they are likely to be able to meet the requirement with some relatively free options like reading articles in various journals. Let's pivot now to the infection control risk assessment. This is an area I'm finding particularly is a non-compliance area in many of my surveys. The interpreted guidelines require an annual risk assessment tailored to your ASC services, patients, and local risks, like MRSA prevalence, for example. And I just again this last week, I was asking for the infection control risk assessment. She showed me a copy of it. It was not dated, and she said, I didn't realize I had to do this on an annual basis. And I didn't even know when it was last done because there was no date on it at all. So indeed, the interpreted guidelines really do specify that it has to be done on an annual basis. And just think about it. Things happen. You take on new cases. You have new risks in your community. You have changes in your patient population. You have changes in the doctors that are coming or the patients and where they might be coming from. So there's various things that have to be taken in consideration as part of that risk assessment.
Yeah, so the way it's done, you score the risks by likelihood and severity. So an ASC doing cataract surgeries might prioritize endophthalmitis, while one doing orthopedics might focus on surgical site infections. And they also take into account what you've done to mitigate that risk.
That's correct.
So, you might do a policy, you might do staff training, and that's why John has mentioned before, it should be changing each time, because even if, the risk of certain illnesses or certain infections are higher for you, you should be changing that by what you're doing. It might always be a higher risk, but it shouldn't end up as high because you've done some things to mitigate it. So the scores should be changing annually, and you should be basing your infection control program on what you're finding there. And so the CDC's infection control assessment tool is a great template to use. And the guidelines expected to drive your surveillance and your QAPI priorities, as I said.
Right. And, there are some other great tools out there. I know that Kaiser Permanente, for example, has a great tool. That's the one that we tend to use at Ambulatory Healthcare Strategies when we're recommending tools. So, again, keep an eye out. But surveyors are going to expect you to use a tool that's specific to your ASC and, of course, updated annually. Or whenever risk change, like if you take on a new procedure, it's probably time to do that infection control risk assessment. Or, we have a couple centers, Sue, that are actually moving into new facilities. Those are going to present different risks. And as a result, they're going to have to change their infection control risk assessment. Generic assessments violate those guidelines, and they're just not going to pass the scrutiny. Let's now talk about monitoring infections and surveillance. So monitoring the infections or looking for infections by talking to your doctors or talking to the patients is critical. And then, of course, surveillance like hand hygiene, sharp safety, and environmental rounds are critical for early detection of issues, as the guidelines emphasize.
So you should use CDC definitions when you're tracking infections like SSIs per 100 procedures. Small ASCs can monitor process measures like antibiotic timing and conduct post-discharge follow-ups to catch SSIs or communicable disease exposures, which the guidelines recommend for comprehensive surveillance. Something people don't always understand, the infection tracking.
Yeah.
I've heard of places that begin by tracking really quite early, like a week or two after somebody's discharged, and you really have to be monitoring for a while, let things let the infection take hold.
Right.
Before you monitor. So, make sure your timing is right on that.
Yeah, we recommend waiting about 30 days after the procedure is done before you actually go back to the doctor. So the most common way of doing this, as you're kind of alluding to, is sending a list to the doctor of all the procedures they did in the last month, and then having the doctor or the doctor's office respond to that list. And to your point, Sue, following up with the patient a couple days afterwards probably isn't going to really help you because in most cases they're not going to see the infection manifesting itself at that point. So let's just kind of talk a little bit about surveillance activities. And the expectations of most of the accrediting organizations is that at the very least you have 3 surveillance monitoring activities. Hand hygiene, as we've talked about. Sharp safety, which we really haven't talked too much about, which is, monitoring for OSHA's bloodborne pathogen standards. You want to make sure you're using surgical safety devices, that you audit it regularly with there's a great ARN sharp safety checklist that we use. And the guidelines expect compliance with OSHA to prevent bloodborne pathogen exposures. And surveyors are going to be checking, sharps containers and the training that you're providing.
And for environmental rounds, you'll want to conduct monthly rounds with a checklist, inspecting ORs and sterile processing. The guidelines link this to the sanitary environment standard, and surveyors expect records of findings and corrective actions like fixing a leaky vent. Like, you don't want to, if you find something, I shouldn't say don't fix it, but make sure to document what you found, how you fixed it, and, keep checking to make sure it doesn't reoccur.
Right. And that's so critical there is I would say, I like to turn this around. Take credit for the fact that you identified that issue in your surveillance and then acted upon it, rather than just fixing it and then, checking it off and saying, yeah, it's all taken care of, or there's no problems there.
And make sure if you have an environmental rounds checklist that a template you've gotten from somewhere, make sure that you customize it to your center. Make sure you're covering all those areas. And if there's something that's not on there and you start noticing, this one area is always an issue, add that to that and really make a point of checking it.
Yeah, you actually bring up a good point. Is I've looked at environmental checklists that have checked off rooms that don't exist.
It looks good.
Yeah, it looks good,
really
but they don't have one of those rooms there. And that's
dirty.
Kind of a clear sign to me that they're not really going through that checklist. So make sure you're not one of those centers. Then let's finish by talking about the reporting to the QAPI committee. The interpreted guidelines require infection control, as we said, to be a core part of QAPI, with regular reports to the QAPI committee and to the governing body, and to demonstrate that the governing body really is overseeing both the QAPI program and infection control in your surgery center.
So your quarterly reports should cover SSI rates, audit results, and QAPI projects, like improving your hand hygiene to prevent communicable diseases. The guidelines mandate documented discussions and actions in QAPI minutes. One ASC reduced SSIs by fixing antibiotic timing via QAPI, and the governing body approved it. the new protocols to support it. So that's a clear path
Right.
from discovering the problem, going through QAPI, and moving it up to the governing body.
And the reason we demonstrate that is that that's a good thing. If that's something that you did in your organization, that's a good way to demonstrate to a surveyor how you identified how you close the loop on that whole process there. So have a good story for a surveyor when you're talking through this area during a survey. So make infection control a standing QAPI item and use a dashboard to include metrics like hand hygiene compliance, meaning, we want to see, quarter to quarter how your compliance has improved or not improved and any actions that you're taking to improve that situation.
And even though we're not talking specifically about governing body meetings here, this is a good place to point out that the governing body is always, in the end, responsible for everything. So even though this is a big QAPI item, as we said, make sure it's going through the governing body and that they're aware of everything that you're doing.
And I can't remember if I already mentioned this here, but avoid those situations like I saw this last week during a survey where the governing body minutes didn't even have a reference to anything with regard to quality improvement or infection control. So they scored very poorly when it came to that section of governing body oversight of those programs. So we've spent quite a bit of time talking about this very complex subject, and we will continue to, of course, talk about it like we generally do here. But we want to stay proactive. We want to document everything. We want to ensure that your coordinator has the time and ASC-specific training like the courses that we offer. And, of course, there's other programs out there that are good also. And you want to focus on surgical site infections and communicable disease risks. And I guess one point we should make here, Sue, is that, prior to the pandemic, we didn't really focus so much on communicable diseases, didn't we?
No.
And I think the reason is because we were always saying, we're not going to have to worry about communicable diseases because we're never going to allow somebody that has a communicable disease. But what we learned during the pandemic is we need to be able to identify what to do if we later find out that somebody indeed had a communicable disease when they came in. And the governing body must empower the coordinator to act on their recommendations to keep patients safe and avoid survey issues like immediate jeopardy. And as a surveyor, I'll add that you need to follow the interpreted guidelines to the letter. Have a tailored plan, have a trained coordinator with enough time to do their job, and a governing body that backs them up. Sloppy documentation or untrained staff can lead to citations or worse, an immediate jeopardy situation. So I think that kind of covers it for now. Let's take a short break, and when we come back, we'll talk about upcoming events in the ASC industry.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So depending upon when we actually upload this podcast, the Texas Ambulatory Surgery Center Society's conference is June 23rd through the 25th at the Omni Los Colinas Hotel in Irving, Texas. And we're recording on Sunday. I'll be heading out early tomorrow morning, and hopefully we'll see a lot of our listeners in Texas this week.
And the Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 23rd through the 25th at the Hilton, Orlando.
And the Illinois ASC Association's annual meeting is going to be October 21st to the 22nd at the Crowne Plaza Chicago O'Hare Hotel and Conference Center in Rosemont, Illinois. And I'll be speaking there. Just finishing up the conference information, and I'm looking forward to also doing a special episode from there this year.
And the California Association's annual conference is September 3rd through the 5th at the Sheraton San Diego Resort in San Diego, California.
And we're going to be doing something unusual or different there, I should say. During the pre-conference, my colleagues and I are going to be doing a CASC review course. We've been doing these CASC review courses for a good 15 years, and we're not doing it really anymore with the ASC Association, but some of the state associations, as we talk about a little bit later, some other organizations have been bringing us in to talk about it. And what's unique this time is we're going to be talking about it during the pre-conference, and then they're also going to be actually holding an exam a paper exam, which is the first time that this has been done in a while. So we're looking forward to seeing how that goes off. The California Association, of course, is the largest ASC association in the country, and it stands to reason that there should be a lot of people that are interested in taking that exam.
And the Atlantic States ASC Conference and Trade Show is October 2nd and 3rd at the Embassy Suites by Hilton Raleigh-Durham, Research Triangle in Cary, North Carolina.
And the New York State Association of Ambulatory Surgery Centers annual conference will be held October 6th through the 8th at the Desmond in Albany, New York. And I'll be speaking at the conference, and we will, as always, do a special episode there. And Ambulatory Healthcare Strategies will be sponsoring a pre-conference on the Monday, which is going to be the 6th. And we're going to be expanding it. Last year we did 3 pre-conference sessions. This year we're going to be doing 6. So hopefully everybody will attend both the pre-conference and the full conference. And I should point out, Sue, that there is no separate charge for the pre-conference. So if you're signed up for the New York State Association conference, the attendance at the pre-conference is for free.
Yep, you'll just have to sign up for it when we get all that pulled together.
That's correct.
The Oregon ASC Association's annual conference will be October 9th and 10th, and John will be speaking at the conference, and we'll do a special episode from there.
And it's going to be a busy month in October here. The Michigan Ambulatory Surgery Association's Education Day is October 23rd through the 24th at the Boyne Mountain Resort in Boyne Falls, Michigan. And the OR Manager Conference is going to be October 28th through the 30th at the Anaheim Convention Center in Anaheim, California. And this is another conference where we're going to be doing that CASC review course. And that's actually going to be the day before the actual conference on the 27th going into the 28th. There won't be a test during the conference, but we will be doing the full day pre-conference on the CASC review course.
And the Joint Commission's Ambulatory Care Conference is November 5th and 6th at the Crowne Plaza, Chicago O'Hare in Rosemont, Illinois.
And the Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th at the Tulalip Resort and Spa in Tulalip, Washington. I'll be speaking at the conference, and as we've done for the last 3 years, we'll be doing a special episode there also.
And the Colorado ASC Association's conference will be held November 13th and 14th at the Denver Marriott West in Golden, Colorado. John will be speaking at the conference, and we'll do a special episode from there.
Yeah, and it looks like we're going to be very busy in October and November on these conferences. So make sure you tune in to all our special episodes. And if you do see me at the conference or see any of our team at the conference, say hi to us, because we love to get feedback from our listeners. And don't forget that on-demand versions of the ASC Director of Nursing, the ASC administrators, and the ASC Business Office Manager boot camps are available on our sister website at asc-central.com, and we'll provide a link in the show notes to those conferences. And we want to remind everyone, as we mentioned earlier, to become a patron member of the podcast. Don't miss out on the benefits of joining our patron program, which is available at asc-central.com. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation compliance, operations, and financial management. And it's really designed with the busy schedules of administrators, nurse managers, and business office managers in mind. So by becoming a member, you gain access to regular Zoom sessions, which are typically held weekly, where you can engage with other patrons and our podcast team, and usually between 2 and 3, sometimes 4 surveyors. But that's just the beginning. Your membership unlocks a wide range of additional resources, including some of our virtual conferences, such as the Credentialing Conference and the Conditions for Coverage Conference. And you're also going to find valuable tools like sample policies, procedures, forms, or our highly regarded fire and disaster drill kits. And your support of the patron program helps to maintain and grow the podcast, covering those essential costs like research, travel, equipment, and production. It looks like we're going to have a lot of travel expenses in the next couple months. So to learn more and to become a member, visit us at asc-central.com.
And thank you for tuning into this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community. And be sure to subscribe so you never miss an episode. We appreciate your feedback and your suggestions for future topics. Please reach out at any time at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here, our sound editor, Susan Cronkite, who, by the way, you're going to be very busy editing this podcast. We're recording quite late in the day, and we've promised never to do that again, but you're going to be doing a lot of editing. Hopefully you'll be able to turn it around pretty quickly. And the executive producer is John Goehle, and we have a very committed research team of Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Your hard work makes this podcast possible. And by the way, more news to come, but we've just hired 3 new people that will be joining our team during the month of June and July, and we'll add them to that list also. Our theme music is from Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we hope to see you in the next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.